Thank you very much, Dr. Kreutzer, and thank you everyone for joining us this morning. Our next speaker is our own Dr. Jackie Weinberg, who is the director of our fetal and perinatal cardiology, and she will be talking to us about fetal echo in Ebstein's anomaly. Welcome, Dr. Weinberg.
Good morning, everybody, and thank you so much. I'm very happy to be able to talk with you guys this morning. Thanks to the De Silvas and everybody for organizing. As Tarek mentioned, I'm going to be talking about fetal echo in Ebstein's, as well as counseling. So we know that Ebstein's is overall a rare congenital heart defect, accounting for less than 1% of all congenital heart disease. The fetal rates of Ebstein's are likely higher than that, owing to a decent rate of fetal demise. Compared to other congenital heart lesions, Ebstein's actually has a relatively high rate of prenatal detection in its severe forms, as demonstrated in these pictures, the graphs here with the red star, as Ebstein's is typically visible on the four-chamber view, which has long been a standard image obtained at screening ultrasound in mid-gestation. We can see that shown here. On the left is a normal four-chamber view in a fetal ultrasound. As you can see, the heart in that normal example takes up less than 1/3 the area of the chest and less than half of the circumference ratio. And at mid-gestation, the right and left atria should be fairly equal in size, and the dimensions of the right and left ventricle should also be closer to equal. In the example on the right of Ebstein's, in comparison, we can see significant cardiomegaly, with the heart taking up probably more than half of the chest area, as well as circumference. We can also see some of the features of Ebstein's in this example. So we can see that rotational displacement of that septal leaflet here, as well as abnormal attachments of the other leaflets, creating significant right atrial enlargement, as well as this is the atrialized right ventricular portion with a smaller functional right ventricle. In these other examples of significant cases, we can see in the example on the left here, again, severe right atrial enlargement and cardiomegaly, and we can see some of the fine details of that tricuspid valve, even by fetal echo, with abnormal attachments of this anterior leaflet here, the displacement of the septal leaflet, or a failure of delamination, the smaller functional right ventricle, as well as a significant pericardial effusion. In the example on the right, we can appreciate with color compare the significant tricuspid insufficiency with a wide jet of insufficiency that arises well into the body of the right ventricle. I'm going to go through a few cases from our institution that I think show a lot of the important points about fetal Ebstein's anomaly. So in this first case, this was a patient who had initially been seen at an outside program and came to us late in gestation at 36 weeks. In the clip on the left, we can see, again, this is the right atrium and right ventricle, and we can see fairly mild displacement of the septal leaflet, but significant abnormal attachments and dysplasia of the leaflets, creating an area of non-coaptation, again, severe cardiomegaly and right atrial enlargement, and the right ventricle in this baby was more on the dilated side and not hypoplastic. The clip at the top shows the degree of tricuspid insufficiency, that large blue jet there, which was severe. On the right, there was no obvious antegrade pulmonary valve flow. This is the pulmonary valve here, and there was no clear jet of antegrade flow to the PA, but intermittent trivial insufficiency, the small red jet that can be seen there. And in this short axis view here on the bottom, we can nicely see the three leaflets of the tricuspid valve, with this being septal, inferior, and anterior leaflets here. This baby had stable findings at 38 weeks gestation, and was delivered at 39 weeks. They did not require intubation or prostaglandin, but did receive a brief period of pressors, inotropic support. We were able to achieve antegrade pulmonary flow, and thus this was a case of functional pulmonary atresia, and a Starnes procedure was not required. They came back at 21 months of age for a cone procedure and are doing well. In this second case from our institution, this was a patient who was referred from our OB practice due to concerns for cardiomegaly on an obstetric ultrasound at mid-gestation. So these images were at 20 weeks gestation, and as you can see in this clip on the left, there is cardiomegaly with the heart taking up more than a third of the chest, with a more prominent right atrium than should be seen. Although in the first clip, the tricuspid valve anatomy is not all that well seen, here we could start to appreciate that the septal leaflet was not obvious and likely displaced, and the anterior leaflet also had abnormal attachments. And with color, we can see that the tricuspid insufficiency jet starts nearly down at the right ventricular apex with a wide, broad jet of severe insufficiency. Not shown in these pictures, but we also felt at that time that we could not see antegrade pulmonary flow consistent with functional pulmonary atresia. At follow-up, this baby had evidence of increasing cardiomegaly, so the CT area ratio at the first scan at 20 weeks was 34%, and throughout pregnancy progressed from 25 to 29 to this clip on the right shows at 32 weeks gestation, the CT area ratio measured 60%. We can also see, better than the first ultrasound at 20 weeks, some more of the anatomy of that tricuspid valve. And so the septal leaflet seen here is very stuck down or tethered to the septum. There's part of the inferior leaflet, and then the anterior leaflet had abnormal connections with a small functional right ventricle. This is a color view at the 32-week gestation follow-up visit, where we continue to see severe tricuspid insufficiency arising from near the apex of the heart. There was no antegrade pulmonary valve flow seen, but no pulmonary insufficiency and retrograde flow in the ductal arch with ongoing severe low-velocity tricuspid insufficiency of note. So this baby was delivered at 37 weeks due to fetal growth restriction and underwent a Starnes procedure at 5 days of age and is now 8 months old and doing well, awaiting the next step. In this third case, a little bit older of a case, but this patient was also from our own OB practice, referred due to an abnormal ultrasound. And in the image here at 21 weeks gestation, we see severe right atrial enlargement and cardiomegaly. The tricuspid valve annulus dimension was large, and there was significant tethering and displacement, not so anatomically distally displaced, but significant tethering of that septal leaflet, and with color, severe tricuspid insufficiency. The right ventricle was actually dilated and had preserved function. There was no, although not shown here, no forward flow noted across the pulmonary valve at that time. At follow-up at 25 weeks gestation, we can see there's progression of the size of the heart in the chest with severe right atrial enlargement. Again, the right ventricle is dilated with decent function still at this time. And on the right, ongoing tricuspid, severe tricuspid insufficiency, but no evidence of high drops. And at 34 weeks gestation, we can see that the size of the right atrium has continued to increase and is very severe. There was also a trace amount of pericardial fluid seen. You can see a little sliver of it here, and appreciate that the lungs are significantly compressed posteriorly because of the size of the heart. In the center, we can see a short axis with the comparison between the left ventricle and the significantly dilated right heart. And on the right, although the pulmonary valve anatomy was not well seen, there is retrograde flow in the ductal arch at that time. No pulmonary insufficiency was seen. So this baby underwent a Starnes procedure at 2 days of age, followed by a Glenn procedure, and then a later Starnes takedown with a cone procedure, and is doing well. So when we evaluate in these cases the severity of the fetal Ebstein's, there's many factors that we look at to provide sort of a global assessment of the severity in order to counsel families. And that includes both anatomical and physiological features. So some of the anatomy that we look at includes the cardiac size, so the cardiothoracic area ratio. We also look at other assessments of the anatomical severity, including the assessment of the right atrial and functional right atrial size to the remainder of the heart, or the Seller-Mayer index. We also look at tricuspid valve annulus dimension, comparison between the right and left ventricular dimensions, as well as anatomic features such as the anatomy of the tricuspid valve leaflets and whether there's true or functional pulmonary atresia. Some of the physiologic aspects that we look at include ventricular function and some of our Doppler assessments, including reversal of flow in the ductal arch, the tricuspid insufficiency, and whether there is a presence of pulmonary insufficiency, as well as the tricuspid valve pressure gradient as a marker of the right ventricular function. This clip on the top here shows an example that we'll see again in a minute of significant pulmonary insufficiency in a fetus, which is a very poor prognostic factor. So there have been several studies coming up with different combinations of these factors in fetal Ebstein's to try and predict mortality and poor postnatal outcome, as well as in utero demise. And some of the important predictors that are included in these different scores, including earlier gestation at diagnosis. The cutoff in one of the older papers was under 32 weeks, although as obstetric ultrasound has significantly improved over time, we are often seeing these patients at mid-gestation. Premature delivery was also a very strong predictor of neonatal death. The other assessments of anatomy, such as cardiomegaly with the area ratio, as well as tricuspid valve Z-score, are important. And lack of antegrade pulmonary valve flow, as well as retrograde ductal flow, and the presence of pulmonary insufficiency being one of the more significant and very important features that can present late. It is very notable that Ebstein's is a progressive lesion during the pregnancy, as I showed in some of those cases, that the features tend to progress and that fetuses may have more of these poor predictors late in gestation than they do in earlier gestation, which can make counseling families at 20 weeks gestation more complicated. In this last case that I'll show, this was a referral to us at 28 weeks gestation, initially seen at an outside practice. And at 28 weeks, there's cardiomegaly and the tricuspid valve anatomy, although not clearly shown here. There was two-fro flow at the tricuspid valve annulus and consistent with pretty significant tricuspid insufficiency and distal displacement of the tricuspid valve leaflets. At 20 weeks gestation, she was noted to have pulmonary insufficiency, or the fetus was noted to have this pulmonary insufficiency. So this red jet of color here is flow back into the right ventricle with retrograde flow in the ductal arch. But importantly, there were normal umbilical artery Dopplers at that time. Unfortunately, at follow-up at 34 weeks gestation, the baby had evidence of progressive fetal hydrops. So in the still frame here, we can see that there's ascites and pleural effusions present in this baby. And the clip on the right demonstrates the significant cardiomegaly in the chest, in the fetal chest at that time. The pulmonary valve was felt to be functional pulmonary atresia, as there was no obvious antegrade flow able to be seen, but with continuous significant jet of pulmonary insufficiency seen there. The Doppler of that pulmonary insufficiency shows that it's continuous, and unfortunately, the umbilical artery Dopplers showed cessation of flow at end diastole and even some clips with reversal of flow. Unfortunately, due to concerns for non-reassuring fetal heart rate tracings, the baby was delivered right away in this case before we could consider treatment with NSAIDs. And although with medical management, and the baby was also very growth restricted, we attempted medical management we turned off the PGE and used nitric and oxygen in order to achieve antegrade flow across the pulmonary valve, which was successful. However, the baby ultimately was very unstable and progressed and did not, unfortunately, survive. A Starnes procedure was not able to be performed because of the baby's size. So that is an example of a true circular shunt, or what we refer to as the circle of death, a very unfortunate circumstance. As is shown in this picture, this does must include reversal of flow through the ductal arch, pulmonary insufficiency, bringing the blood flow into the right ventricle, but importantly, needs to show evidence of true steal from the systemic circulation. So in the fetus, either reverse flow in the descending aorta or reversal or cessation of flow in the umbilical artery. And this is, of course, holds a terrible prognosis with a high rate of fetal and neonatal demise, but also there's evidence of lower fetal brain weight and worse neurodevelopmental outcomes when this occurs. With a circular shunt, the idea came about to attempt constriction of the ductus arteriosus to reduce the degree of pulmonary insufficiency and thus reduce that steal from the systemic circulation, with the aim to improve the fetal hemodynamics and prolong gestation to get the baby closer to term prior to delivery. Of course, to improve survival and neurodevelopment as well. So this was a case series of 21 patients offered NSAIDs across 10 centers, of whom 15 received NSAIDs, and of those, 80% achieved ductal constriction, all of whom had improved pulmonary insufficiency and most with improved Doppler patterns. They showed that the median gestational age at pregnancy outcome was later, which was statistically significant, and there was 92% that achieved ductal constriction survived compared to 44% who either did not receive NSAIDs or did not achieve ductal constriction. So a very small case series or study, but with important results. And other studies have confirmed those findings in other cases, not without risks, so it is always a difficult conversation to have about that. So our counseling for fetal Ebstein's overall includes an assessment of a lot of what I've talked about today, the severity of the anatomy and physiology in each individual fetus, and the risk of fetal or neonatal demise, which no matter what is fairly significant in this disease. We discussed the frequency of prenatal monitoring and treatment in those cases where a circular shunt does develop, and importantly, has to involve discussion of the delivery management, the location, the timing, and what measures will be undertaken from a medical standpoint postnatally, as well as the potential postnatal interventions, both catheter-based and surgical for these patients. Remembering that this is, a very significant fetal disease with an overall, in some studies, close to 50% perinatal mortality between prenatal and postnatal life. These are often difficult discussions. The recent consensus document that came out did include 4 points about fetal Ebstein's anomaly, and this is, tracks along with what we talk about with these families when we meet with them prenatally. Their recommendations included that fetal Ebstein's requires a thorough fetal assessment and assistance from a multidisciplinary team, that certain features that we've talked about today, including, importantly, the anatomic features, circular shunt, LV dysfunction, low right ventricular pressure, development of hydrops, suggest the high risk of intrauterine or postnatal demise, that serial echocardiography is necessary throughout the pregnancy because of that progression that is common, and that these babies should be delivered at experienced centers with a high level of postnatal multidisciplinary care as well. Thank you all for coming this morning, and I'm happy to answer questions at any point if they come up. Thank you.